Hi there, greetings and welcome to this exciting webinar. My name is Chris Call. I am a critical care flight paramedic out of the US, as well as a technologist and in marketing. I am here, I guess I should say, I am so blessed to have this roundtable of amazing folks with us. Today's topic is about creating a regional system of care and how these leaders, along with their comprehensive medical teams, changed how they assess and treat patients. Today, we're going to be talking about their systems, the challenges they faced, and what they changed and implemented and the outcomes they've seen. But first, let's just start with introductions. Our first one is Professor Chris Bladden. Chris is the Victorian Stroke Telemedicine Service Director, the Adjunct Professor at Monash University. Chris, tell us a little bit about yourself.
Yes, Chris, thank you very much indeed. My name is Chris Bladden. I'm a neurologist. Practicing neurologist with an interest in stroke. I have a strong interest in research, and what led us really to Pulsara in the beginning was the fact that I could clearly see a gap in how we were communicating, and my research in that took me to obviously many conferences. And in the course of that, I came across the Pulsara team, and that led to a long and very fruitful and beneficial discussion and subsequent grant submissions and finally implementation of Pulsara at a number of regional sites across Victoria. And it's been a very productive partnership between us and Pulsara, and in the course of my journey I have become the Director of Stroke in Ambulance Victoria, and we have integrated this really well in a number of regional hospitals, which I'd be happy to talk about today. So thank you, Chris.
Perfect. And Dr. Katie. Katie's a Senior Research Officer of the Stroke Division, Public Health and Health and Services Research Group. Katie, tell us a bit about your background.
Thanks, Chris, and thanks for the invite for today. My background is non-clinical. So I started project management in the corporate world in the 90s and ended up here in the last 20 or so years doing research in social science, implementation science, understanding individual and group behaviour change and individual and group behaviours. And most recently looking at implementing technology-based improvements into clinical care processes. So obviously Pulsara today, but also things like the telestroke service that Chris Bladden just mentioned, and mobile stroke ambulance is another recent example.
Thank you. We're going to dig into both of your backgrounds and a lot of what you're working through. But first, let's jump in with Janet. Janet May is the stroke coordinator at Latrobe Regional Hospital. Tell us a little bit about yourself, Janet.
Yeah, thanks, Chris, and thanks for the invite to speak today. My background is clinical. I'm an emergency nurse. I've been emergency nursing for 23 years, which makes me sound old. I've previously held positions as Associate Unit Manager and Clinical Nurse Specialist, both in tertiary referral hospitals and in regional Victoria. And now I do a dual role working in emergency and also a stroke coordinator down at Latrobe Regional Hospital. I first became involved in Pulsara as the project manager for the hospital late in 2019 when we first looked at implementing it. And then we went go live in early 2020. And I still do the day-to-day operation things for Pulsara as part of my role as stroke coordinator.
Thank you. And rounding out our panelists, we have Paramedic Grant Hawkins. Grant is the Regional Improvement Lead at the Grampians Regional Operational Improvement for Ambulance Victoria. Grant, tell us your story.
Thanks, Chris, and great to be here with everyone today. If Janet thinks she sounds old, I've been with ambulance 35 years, so I must be old. In that time, I've been a MICA paramedic for about the last 27 years. And clinical manager prior to becoming the improvement lead just a couple of years ago. So clinical manager was educational focused, and Grampians region of Ambulance Victoria became involved in Pulsara in 2017, so quite a while now. My interest was obviously in the technology to make improvements And prior to that, I had been on the Victorian Stroke Clinical Network for 7 years as a representative for Ambulance Victoria. So everything just gelled nicely together at that time, and it's been going strong ever since. Thanks.
Yeah, as you can see, we have a great group of panelists. We have the nursing side, the PhD doctor, the neurologist, and the ambulance paramedic pre-hospital side. And so part of our objectives are talking about healthcare, but not the four walls of the ambulance or the four walls of the surgery suite or the four walls of the emergency department, but instead, how do you build an entire regional system of care? And if you think about it from the perspective of the patient, they don't have four walls of just an ambulance or the clinical suite or the emergency department. They start maybe at the home and they're transported. And during their journey through their care happens with a lot of moving parts and a lot of people. And how do you get everybody on the same page? So the first question will be to you, Chris. Dr. Bladden, a few years ago, you guys started looking at how to best tackle some challenges you face. Dr. Bladden, can you please share a little bit about the clinical landscape and some of those challenges you are looking to solve?
Yeah, it's a really good question, Chris. And, as with all these issues, these complex issues as an interface between the community and the hospital, you have to look at how you can best do that. And the thing that struck me, way back in around 2013, 2014, when we really started thinking about this a lot, was that when new patients had to come in, particularly stroke patients, which is my focus, had to come in quickly, and that the communication between the outside world, the community world, and the hospital was key to that. And there was hospital pre-notification of patients coming in, but it was clear to us that that was difficult. It was patchy, and certainly in the environment which I was increasingly starting to work in the regional environment, it was can I say, less mature, maybe less sophisticated than it was in a metro environment where a lot of those systems are embedded. So I was really looking at that time to utilize digital technology, digital health apps to try and facilitate that. And I did a scan of the landscape, and needless to add, back in those days, there wasn't a lot around, but by going to conferences and just talking to people, I ran into James Woodson, who is the CEO of Pulsara, and Pulsara was a much smaller entity back in those days, and we started a discussion, and that kind of evolved over several times, and indeed Pulsara itself was evolving and the company was evolving over that time. But by about 2014, 2015, it was clear that this was something we really needed to test out. So I guess our approach into this was in keeping with my background, which was we need to do some research into this. Does this work? It looks good. I'm a nerd. I love this stuff, and I love to use it. But that's not the same as is this actually going to be beneficial for patients? Is it going to be beneficial for and reduce complexity in the communication processes between ambulance and hospital? So that led us to put in a research grant into the Heart Foundation, and we followed it up with a research grant into the Stroke Foundation. And we, to cut a long story short, we established Pulsara and tested it out across two key hospitals, Bendigo, then Ballarat Hospital in regional Victoria. And that research project went for several years. And Katie was the rock star performer in that process in terms of organising implementation of Pulsara, keeping everyone on track, keeping the research protocols tight. And I should add, the Pulsara team, without wanting to talk them up too much, but they were fantastic, and they came out to Australia and did a number of site visits and really helped facilitate the implementation into both ambulance and hospital. And the key thing about this, I guess, is that it's all very well to ring ahead into the hospital, but and let the ED, the emergency department, know that you're coming in. But of course, the communication reach has to be so much further. It has to really go into those core components of the hospital that are going to actually impact patient care. So for us in stroke, that is, notifying the people in the CT scanner that there's a patient coming in. Notifying the docs on the floor in the regional hospital that there's a stroke patient coming in and we're going to be giving could be giving thrombolysis. They need to get down to the ED and quickly assess the patient. So it's that ethos of time is brain that we really wanted to address. Now, my background is stroke, but clearly stroke is a small part of emergency admissions to hospital. So Pulsara was geared up towards stroke and STEMI. So we took the sensible approach was these two conditions have a lot that align themselves. Similarly for STEMI, you need to reach into the ED, but you also need to reach into the cath lab for emergency PCI procedures for cardiac thrombolysis, etc. So the two conditions linked up very well, and we used that as the basis for starting this research project across the two hospitals to see whether that communication process would be improved. And we knew from research, particularly research that Katie did, was that there can be 5 to 10 different phone calls just to convey information, and as so often with phone calls, that information can get just a little bit twisted, and the nuance of some clinical elements can change. And having everyone on the same page with the same information, which is what Pulsara does, is really a key for us. So, I can go over the research results, but we found really across the board that Pulsara improved the timelines in terms of processes of care. I mean, just to give one example, for us in stroke, we found that door to CT time was about 44 minutes faster. And door to PCI, door to balloon times for STEMI was at least improved by at least 17 minutes. But there are a number of other processes of care that, in fact, the timelines got better and better. But that doesn't really that talks about pure metrics, but in many ways it's the qualitative improvements that really made the difference. And what I might do, Chris, is perhaps throw to Katie just to talk about the qualitative elements of this, because this is Katie's area of expertise.
Yeah, that's a good lead in because that was my next question. I think that you said two things that were really important. One, technology for technology's sake, while that may be fun internally off the record for friends and family, it really has to impact patient care, number one. And number two, the way that we do things clinically, it's not how we communicate in real life, right? I don't emergently fax a grocery list to my son to pick up milk, and I don't page Katie to see if she wants to connect with me later after work, but yet that's how we do it during a time-sensitive emergency. So Katie, everyone's looking for that magic bullet, the quick fix, buy this product, enable this leadership strategy, stop doing this, start doing that. But as the PhD doctor in the group, the one who talks about tracking change, tracking data, and all these small changes, can you speak a little bit to that and implementing those changes and that strategy?
Yes, definitely. So, as Chris said, it really was a multidisciplinary approach that we took to, looking at Pulsara and implementing it. And one of the first things that we did was, in terms of implementing change, we looked at it from two different perspectives. One was from a system level and one was from an individual level. So talking about that system level, we got everybody in the same room from all of those different, pre-hospital people, ED, triage, radiography, cardiology, neurology, everybody across to talk through the process from start to finish as to how communication currently worked. So everybody then got an understanding of where everybody was at and how it all worked. And even during that process, we found that change already started happening because people in the room were going, oh, I didn't know that that's why you did that. I oh, is that why that takes so long? Oh, we didn't know that. We just thought you were just dragging your feet. So there was all of this interdisciplinary understanding that was coming out from that. And then we looked at it from an individual perspective. So I spoke to different, individuals across all of those different areas. We did a whole lot of surveys with those individuals as well to ask about what works and what doesn't work, so that we understand the current communication processes and the current, things that do and don't work. And then also ask them about Pulsara, or about a single communication system. What did they think the benefits of that would be, and then what would the concerns be? So we could understand what possible things would help change or inhibit or delay change. So, and then we tracked every single time point for the patient care journey, from pre-hospital through to the delivery of care. We had to go to multiple systems to find that data, so it is time intensive and tricky. But that then allowed us to evaluate pre the app what was happening at each stage, and then post the implementation of the app to be able to see where it had improved, where it hadn't, and be able to investigate case by case, but also at an aggregate level. So that was sort of the approach that we took for looking at how change and how the data helped.
Yeah, and we'll get into some of the data as well here in a moment. Janet, you were really on the implementation side for Latrobe Regional Hospital. Streamlining communication was a big focus, both to improve patient care, but also strengthen that collaboration with all those involved. So up until the beginning of around 2020, Latrobe Regional used a combination of phone calls, pagers, to interface between emergency services, the emergency department, hospital staff. Can you speak to that implementation strategy and that outcome?
Yeah, sure. So in early 2020, we brought in Pulsara for pre-notification. We used it mostly for acute time-critical patients. You can use it for everything coming in, but we were aware that we didn't want to over-alert the emergency department as well. And we also set it up for the internal teams. So like Chris said earlier, we had it set up for stroke teams, trauma teams, STEMIs that were coming in. And they all would receive the same information that what the Ambulance Victoria crew had put on Pulsara. And we're also expanded it as well now, so we use it for our inpatient strokes on the wards. So if there's a Met call and the med reg is there, you can put the information all on Pulsara, and then it's shot down to CT room. The stroke coordinator and the hospital coordinator all know that where the stroke is. And I think overall the best outcome we've had is quicker treatment times for patients, because it's really streamlined our communication right from pre-notification into the ED and then to our internal teams. I think one of the big things we noticed was the reduced inaccuracy of the patient demographic data coming in, because we used to have a BAT phone, or we still do have a BAT phone for backup, and it was a dedicated phone line that the ambulance would use to call in for anything acute time critical. So the way that would work is the AV crew would have to call centre control, who would then call us on the BAT phone with what was coming in. And if we had to clarify any details, or sometimes in outlying Gippsland areas, there's phone services patchy and you'd miss their name. We couldn't clarify any of that until the patient was on the doorstep. So now we have all that information, and we reduced all those data errors. And also for those patients, you get a lot more clinical information on Pulsara than just a name and a date of birth and a stroke or a trauma coming in. So it's actually, we think, lessen the administration work that we've had to do with multiple phone calls once the patient comes in, and then the nurse in charge would have to initiate a stroke page and then call the surgeons in theatre if it was a trauma. So all of that's gone, and they just flick the Pulsara notification to the team. So they're all on the same page at the same time, which is good.
Yeah, being all on the same page at the same time is so important. And I know, Grant, this next question is for you, that we've talked in the past that you have a great relationship, the ambulance, with the hospital. And so when it comes to the ambulance crew and the paramedics with the emergency department, those relationships have been there. They're great, but you really are the backbone of out-of-hospital medicine, from urban city to the rural countryside. And there's a major role that paramedics play in this regional system of care. And so tell me a little bit of how those relationships have changed over the last few years as you guys have implemented this regional team approach.
Thanks, Chris. Yeah, so we've always had, as you said, a great relationship with the hospitals through the emergency departments. And that hasn't changed. The paramedics know the emergency staff quite well, get on very well, good relationship. And it doesn't really extend beyond the ED in most cases. There's some examples where it does, but and that relationship hasn't changed. And in the past, when we would let the ED know we were bringing in a time-critical patient, we did that, as Janet has said, via radio or phone, via a third party in our communication centre, usually the clinician. And we would include things like vital signs, medications, allergies, patient name, sometimes date of birth and UR numbers, things like that. But typically, as Professor Bladen mentioned, that once it went beyond the ED and they went to let somebody else know, they'd always just basically get told, there's an 83-year-old female with stroke coming in. They wouldn't get all that other information. And that was a regular occurrence of me at the Stroke Clinical Network meetings getting asked, how come they only told us age and condition, the presenting condition? So, yeah, there's communication issues there. So, but now, obviously, our patient notification has improved significantly. We feel like we're more part of a greater team that includes neurology, radiology, cardiology, medical specialists. So, it's a bigger a scope now. And the messaging obviously exceeds beyond the emergency department, so we're all connected at the same time, which is brilliant. For us as paramedics, that means a lot because we're about patient-centered care and best care for the patient, and it gives us a lot of confidence to know that now in the background everything's being done as much as possible to get ready for the patient's arrival. And we've seen the results. The care is much more immediate and the patients do have better outcomes. Everyone can see the patient details. We can now transmit ECGs, much better quality than what we are doing in most other parts of the state, which is using fax machines. We have immediate communication, that we can get asked questions, we can send in more details as we get it. We're all working together much better. So the relationships are vastly improved. And everyone feels more empowered. As I said, we feel more confident. We know the patients, the staff at the hospitals can see the results themselves. So we're all more confident and more empowered. Everything's transparent, more immediate. It's just a much better system to what we were using. The results, it's been mentioned, a couple of the results have been mentioned by Chris, but, for us, for ambulance, we were getting patients off stretchers 5 minutes quicker than without Pulsara. We were clearing hospitals 10 minutes quicker than without Pulsara. So on our side of things, that made a huge difference. For the patients, Chris mentioned, the daughter CT scan for stroke patients is, 45 to 51 minutes quicker. Door to needle times much quicker. And we've got a target time of 60 minutes for stroke patients to get thrombolyzed in. And that more than doubled. So we went from 11% up to 25% of patients getting thrombolyzed within that 60-minute target window. So the outcomes speak for themselves, really.
Yeah, this is so great. In fact, it sounds like I paid each and every one of you millions and millions and millions of Australian dollars to say all these great things about Pulsera, but that's not true. In fact, not everything is perfect and not everything goes as planned. And yet, at the end of the day, it really is about doing the right thing for the patient and being on the same team. That's really what we're talking about here. But not everything goes perfectly, and I'm sure there were challenges and hurdles. And so for the next little bit, I'm just going to kind of throw out some questions. The first one is, for others who are looking to create a regional system of care where you're taking down all those hurdles and silos and all working as one full team, regardless of your discipline, I think Katie said a couple times, interdisciplinary teams, what is your one piece of advice And I'll let Chris go first, and then we'll just kind of jump in.
Yeah, look, Chris, I've got a really good example of that. I guess, it's a case of you have to tailor the approach that you want, and it's not a one size fits all. And a good example of that would be some work we did at one regional hospital that was starting up their cath lab, their PCI cath lab for STEMI, right? And so one of the issues that came up was that we set this up and we thought we had everything lined up beautifully, and then it turned out that the processes we had put in place didn't quite fit the nature of the calls for STEMI that were coming in. So a call for STEMI would come in, and the problem was that the review of that and the confirmation that case actually needed to go through the cath lab wasn't quite right. So there would be a lot of false calls. And so in the middle of the night, the app is going off on the phones of the cath lab staff, right? And then the next 10 minutes later, stand down, you don't need to get out of bed. But this is not really a STEMI, or this case is not going to the cath lab. And so that caused friction, as you could imagine. And then when the cath lab moved from a sort of a part-time scenario to a 24-hour scenario, that became a bigger issue and caused difficulties. So we had to then go through a process of reconfiguring that such that rather than just having a sort of a blanket approach to notification, we would flip that round. So, for example, the paramedic could contact the cardiology registrar, who was then becoming the gatekeeper for assessment of the STEMI case and activation of the cath lab staff. We could reconfigure that so that the calls were in fact going through to the registrar and the cardiology registrar, who was taking the first call from the paramedics. And so that then can allow for more tailored, a more nuanced approach, and that's is going to improve things substantially. I guess the other thing I want to point out is that we've been on a long journey with Pulsara, and when we started, it was stroke and STEMI all the way, right? But of course, we've evolved, and certainly Pulsara has evolved to have a number of different applications now, and it can be used for any type of acute emergency presentation. There's a number of different modules inside Pulsara. And I think that for us opens up a lot of possibility in terms of, again, tailoring the alert process. So if you know that a STEMI is coming in, you actually follow a slightly different pathway using Pulsara than, say, for perhaps a stroke. The other big challenge that is kind of on our doorstep and will be familiar to many people here in Australia is the arrival of the electronic medical record. How do you integrate some of the information from Pulsara into the EMR? So that's a challenge that I know you guys have thought about, and I'm sure it has come up in the US as well. But that's sort of the next digital transformation that's happening in the hospital system. And, the care of patients really starts at the bedside when the paramedic arrives and, comes through the front door and sees that patient with chest pain or with, weakness down one side or a broken hip, for example, whatever they have. That's when medical care, that's when hospital care actually starts. It starts at the bedside. So, there's no reason why that information that's gathered at the bedside shouldn't go all the way through to be embedded in the hospital record. It's not, we talk about silos all the time. It's not a silo outside the hospital, and inside the hospital, it's not a them and us type silo situation. We need to have that much closer integration. And with COVID, of course, things have changed as well. So I know Janet's obviously here today, and the guys in Traralgon have had a really good experience with using Pulsara to manage suspected COVID patients come in. So I'm going to take your role here, Chris, but you could ask Janet a question perhaps about that, because COVID is certainly fresh on all our minds.
Yeah, Katie, one of the things you had said, I think, about some of the hurdles is that everybody needs a chance to have a seat at the table. And I think it was Janet that not everybody likes change. And so why don't you two speak a little bit about when you do make those changes, how everybody wants to have a voice and they want to be heard. And when you're implementing changes like this, it's a big deal.
A big deal. And not everybody's at the same place at the same time ready for that change. So Chris Bladen, as you may have already suspected, is very much an early adopter. He is go out there, find the new fantastic thing. Yep, it's going to work. This is great. And then he would bring it back to the Flory where we were working at the time, and I would sit there going, I'm really not sure about this whole app idea. I'm not an early adopter. Chris is an early adopter. So we worked through all of that, and that's the same with people in the hospitals and across the different areas. So my number one tip is for doing this. I mean, I have a million tips, so, hit me up if you need tips. But this, to go in with this one is about having hands-on practice. Everybody wants to do a good job. Everybody wants to do the best by the patient. And so they've worked out ways that they do that now. That's how they're practicing their clinical disciplines as they currently work. But we have these habits that we do in order to do those things. So we need to be able to, by giving people a demonstration version of the app on their phone, it gives them hands-on experience so that they can build confidence and go, oh, yeah, it really is as simple as just texting and doing it and taking a photo. That's what you told me, Katie. I didn't really believe you, but now I've had a go. I can see that. And then they could see that the app would actually work. So that then builds trust. You're thinking, oh, so they've already responded to me, even with the demo version, so that they could see all of that. And that then helped change those habits and going, oh, well, this is a different way that I can do, that can work. And okay, now I'm really interested. So that hands-on practice was really key. Now there's radio silence. So
yeah, no, that's great. I was going to have Janet jump in as well.
Sorry, yeah. I'll probably reiterate a bit of what Katie said. Like, it's with any change management thing, you're going to have people that are excited, people that go with the flow, and then the occasional blocker. And one main thing we found useful is more from an end user point of view is having kind of super users on the floor, because the project managers can't be there all 24/7. So if you have some super users on the floor, even after hours, that are very familiar with Pulsara or any sort of change, they're there to help iron out any hiccups, answer any questions before they kind of escalate and everyone has, the negative attitude. So, and bringing your stakeholders to the table early, like we had our executive sponsor, CT managers, the AV community liaison people were there with the first meeting. So we all knew what was involved with rolling it out. So, yeah, I feel like we had a pretty good implementation, and I've got to thank Mark Scammell from Ambulance Victoria and my co-worker Caroline in emergency for that, because they were a great team, and, knowing your own team and just being on the floor a lot more than what the project managers could really helped. So.
And Grant, I think you were saying that there's every once in a while it didn't matter if it's at night or during the day, on the weekend or a weekday, there's always somebody to help support your efforts.
Yeah, that's right, Chris. And just to back up what others have said, but having a champion, as we call them, or a super user available. So we did the same thing in ambulance, 4 years ago when we first implemented it, was put in place these champions so that they were always there. But I think the other key thing, just to pick up something that Katie said, was not just the champions, but that initial concept of that, I guess it's human-centred design, where everyone's given an equal opportunity to be informed, to be listened to feel valued in the process. And I think that helped a lot. And Katie was magnificent in that role in ambulance and at the hospitals, with the introduction of Pulsara and setting up those meetings that she mentioned earlier, where everyone got around the table, and the understanding and acceptance acceptance of everyone's role during those meetings was just fabulous. And it really helped establish Pulsara, the project, as something that everyone was eager to get involved in. And it continues to today. So we've now got, as getting back to the first statement I made, the relationships with those people at the hospitals are still strong today. So, you know, it wasn't just so much about Pulsara, but it improved a lot more things outside of the project itself. So it was amazing.
Well, Chris threw us a curveball and said, oh, by the way, ask Janet about this, this, and this, which is important because it isn't just stroke or STEMI. You know, it's a team-based approach on telemedicine. And all of a sudden, when you step back and say, well, if I can connect the right people at the right time to take care of this patient, all of a sudden you start thinking in strategy of like this initiative or that initiative. Chris, Dr. Bladen, you said we used it for management of potential COVID patients. So Janet, I'll have you speak about that. And I know personally I've read up on some of the things that you were working on with mental health and behavioral health and some of those items. So let's speak about that, Janet.
Really helpful with suspected COVIDs we called them. So when the ambulance were bringing them into the department, they would Pulsara it so that without them having to enter the department in PPE, we would know that they're at the door and we would send someone out. We had half the emergency department set up for infection control, so in isolation. So the staff from that area would go out, meet them, triage them out in the driveway, and then they would get onto the ED bed there and then come into the emergency, into the infection control area. So we wouldn't have potential SCOVIDs coming through sort of the clean end of the emergency department. And we used it obviously multiple times during the height of our COVID in winter last year. We as you know, in Victoria, had quite big numbers for Australia. And it was really helped filtered out that risk of having infected patients coming through the ED. The other thing we saw a good opportunity for was we have a really high presentation of mental health patients here. So we looked at how we could use Pulsara for them as well for pre-notification coming in. And we have a unit called MAPRA, it's the Police Mental Health Response Unit, and we have a registered nurse who's employed by LAH, and she's based at a police station locally. And they would go out and address the mental health patients in the community. And these patients don't always need an ambulance to come in, so sometimes they will just come in with the police and the mental health registered nurse. So we've put Pulsara, it's a bit of a work in progress, but we've put Pulsara on the registered nurse's phone, the mental health nurse, so she can pre-notify ED of any mental health patients coming in. And then the ED nurse in charge can also notify the internal mental health team that that patient's coming in. And quite often, being a smaller community, they're familiar with the patient, so they know what strategies work for them. So we can kind of have them in place when that group of patients as well comes in. So it's a really useful tool, like I said, not from just what it was originally intended for strokes and STEMIs, but we found for SCOVIDs and mental health, it's got a huge opportunity out there for other areas you can use it in.
Things that you guys are seeing as far as strategic initiatives or opportunities for your community?
So that would work where the coordinator or the bed manager from another hospital can directly communicate our hospital coordinator. It doesn't have to go through an emergency or the other internal systems, and it will work vice versa. So that's another opportunity, I guess, we're exploring at the moment.
One of the things, circling all the way back to the beginning, was based on the data, what would you describe as your number one win that you'd like to share with others? What are you most proud of when it comes to treating the community? And I'll let each one of you answer, starting with Grant.
Thanks, Chris. Yeah, so the number one is just best care, patients' best care. So we've now reached a position where we had what was happening, and as I mentioned some of the data earlier, but we can see now that we're doing much better for our patients. So overall, whether it's stroke, a STEMI patient, a trauma patient, no matter what mental health patient, it's actually improved and as I said, streamlined their care and made improvements across the board. So best care for patients.
The number one win for me is that we actually made it happen. And I have to say, when we first started doing this, and I was working closely with Katie on this implementation, the more I went down this rabbit hole, the more I realised that this was a big task, and there were so many different players. And as Katie's already highlighted, people were bringing so many different perspectives to the table. And as Katie's highlighted, I tend to be an early adopter, and I had perhaps mistakenly assumed everyone would think this was a great idea and let's run with it. But it was a very, not so much sobering, but it was good to reflect on the fact that that adoption curve is got a lot of ups and downs in it. And while I may perhaps be at the front end, there are people who I think they're termed laggards who are down the back end. And in the end of the day, you've got to bring everyone along. And so it was important that we have everyone in the room, that we get them talking together, and we really instill in everyone that this is there's a common purpose here, and it is all about doing what's best for the patient. And yes, I know that you've used the phone for 100 years, and that's how you've always done communication. But you're making 3 or 4 phone calls to achieve what could be done with 1 or 0 phone calls, because the information's instantly available to you. So bringing people along, I think, is really important. And as has already been highlighted here today, having people on the ground who were project managers to really get this up and running was a very key step, because every so often someone just wants to drift outside the tent. You've got to pull them back in, get them back on the same page, and make sure that that they understand their role in all this, and get the whole thing running efficiently.
Yeah, I was here. It just turns out that you guys are even more polite than I am, waiting for each other to speak. So I was waiting for somebody else. But man, Chris, when you were talking about that, it reminded me when Katie said the number one win. We're now communicating how we should be communicating present day, and it was great. Maybe you can speak a little bit to the fact that while you worked in the hospital, while you were clinical from the data side, you weren't necessarily clinical from the practice side. And so when you sat at the table and heard how you were communicating, I think the word was, I was horrified to see, this is how we communicate during a time when time matters. What would you describe as your number one win?
That's true. I would come out of meetings, I would ring Chris and I'd go, is this true? This is what they're telling me. Is this true? So, because we were implementing paperless faxing in 1991. So to be going into a hospital and then being shown a fax machine in the ED area and going, sometimes those ECGs drop down there and then we have to move them, my mind was blown. So the number one, I agree with what Chris and Grant were saying. The patient care. It's amazing that we did it. We did do it. It was great. We had a lot of help, and there was a lot of great goodwill from everyone in the hospital when they saw what it could do. There's a lot of interdisciplinary care, patient-centered care, like we've talked about that today. And what we did was we put a patient-centered communication system into a patient-centered care model of care delivery. And that's what that Pulsara app does, is it takes you right from the start of the patient journey that Chris was mentioning at the bedside in the person's house, all the way through to the treatment being delivered. It's one system. Everyone who needs to see what's going on can see what's going on. You can see all of the important bits of information. You can ask for information that might be missing just by typing something in, and someone will respond. And then at the end, which is where the data researcher gets super excited, is that all of that data is in one system. We had to go to 5 different systems to work out what was happening pre-Pulsara for stroke. We had to go to 5 different systems in the hospital to find out what was happening for and Ambulance Victoria to find out what was happening for cardiac events. And with Pulsara, it's all in there in the one system that you can download out into Excel. So putting in a patient-centered communication system in order to support a patient-centered care model was, my number one win.
I love that. As a clinician of almost nearly 30 years, so I'm right there with Grant and Janet. Technology that works for the clinician to help them focus on what they do best, which is take care of patients. You just don't see that, right? And you guys are focusing on the outcomes, you're focusing on morale, you're focusing on communication, but you're really focusing on the patient. And I love, there's two things you guys said throughout today that I want to reiterate and ask Janet about, is that one, everything is streamlined. And then the second thing is that you guys shared that everything is transparent and everybody can see where everybody else is and what they're doing, so that there isn't any miscommunications. Do you want to speak a bit to that, Janet?
Yeah, well, we've, as I said before, I think we've really eliminated a lot of our patient demographic data coming in. So the internal teams can see exactly what's coming in. So it's really helped, I guess, sped up the whole process. So I think before when you said about what we're most proud of, it's the same, I guess, as what Grant said. It's quicker treatment times at the end of the day to the patient. You don't have to spend time doing multiple phone calls. And we used to page the stroke page, text page, stroke page to old pages to the doctors. So that's all being cut out now, and we've had a 68% increase or improvement, I should say, on our daughter CT times just for our stroke patients. And that always, has a flow-on effect because we've cut out all that doubling up of data. We have an iPad at the ward clerks as well that see the Pulsara information. So when the details come in from the AMBOs, they put the medical record number and confirm all those details. So that's all done before the patient comes in. So it's certainly, cut out a lot of time.
Great. I think we're going to finalize and finish with the last few minutes with some questions. We got a number of questions from the audience, and I'm going to ask the first one, which is, and I think you guys spoke to this a little bit, but I'll have you guys jump in. Katie, I'll actually have you take this one. It says, the question is, how complex is the Pulsera system? Is it easy to set up or adopt, or is there a big learning curve?
That's a great question. There's two elements to it. One is getting it into the hospital or AV, the ambulance side, and then at the individual level. And it was easy. You had to have your hardware, like your mobile phone or your iPad that Janet mentioned. We put phones in trucks, but then eventually that's gone on to the app is now on the ambulance truck phone that's already there. So, and then there's specific devices in the hospital settings. There's a back end that people in the hospital can then control so that they can add users and move users around. But the Pulsara team, they came out from the States for a few days and they helped, set all of that up. They worked with all of the people from the IT group all the way through to the clinicians. We worked closely with them. We had the project managers involved at the hospitals, which, were local people, local clinicians, part-time. And then the learning curve, I had a paramedic who said, no, this is not for me. I'm old school. I'm just going to get the young guns on the truck. They'll use the app. And I said, look, come on. Here's a chocolate Freddo frog. If you have this, we'll then do the, I went through hundreds and hundreds of Freddo frogs. If you can text and if you can do a photo, take a photo on your phone, then you can use Pulsara. So he was very dubious. I got him to do it on my phone, on the truck phone, for the demo, I got him to do it on the ambulance phone. And then within an hour, not a word of a lie, within an hour, he was out in the community. They had a patient with suspected stroke. He used the app as the ambulance is in the bay and they're pushing the patient through, he's yelling out to me, Katie, I did it, I've used it, we did Pulsara, look. And I'm thinking, just get that patient into ED. It's going to, so it was really easy.
That's fantastic. I love that. Janet, when you're talking about another question from the audience says, we are already using multiple communication and telehealth systems. Is Pulsera redundant?
No, definitely not. Well, it's not redundant. I think it complements the systems that you already have. It enhances your workflow that you already got. And it actually cuts out the paging and the multiple other processes that you do have as well. So I think it just helps streamline and enhance the processes of communication strategies that you're already using, really. We found, just to add a bit to the last question as well, we found the system quite easy to set up in that from more of an end user point of view. We had an online training session and I think it was only like 15, 20 minutes that the end user actually has to do to work out how to use Pulsara. And to be honest, you don't even really need to do it because you can teach yourself. It's good to do because you can see all the extra features. But I think it's very user-friendly and we found it quite easy to implement.
Perfect. And let's see, we really only have time for maybe 2 more questions. We want to value everybody's time. To give up an hour to listen is great, and we're humbled by that. So the next one is Grant, then I'll follow up with the last one with Chris. Grant, how does this model work across your hospital region? You talked about urban areas and then very rural areas. Can Pulsera be used effectively across an entire area health network in both rural and urban contexts?
Thanks, Chris. Yeah, that's possible. We've, in my region, in Grampians region, it's only at Ballarat Hospital, but Ballarat being the largest hospital in our region, takes in patients from a large area, hundreds and hundreds of kilometres away. So when we introduced it, and it's still the case today, we had it in our Area 1, which used to be called Central Grampians. But that goes as far as Ararat and Avoca up to Dalesford. So people that know the area, there's, upwards of a couple of 100 Ks between those communities. And it works fantastically well because, again, those crews coming in, there's a lot more lead-up time for the hospital to get stuff done and a lot more communication happening between the crews and the hospital staff, medical or admin or whoever. So, but what we found, an additional bonus, was a lot of our paramedics, and as Katie said, it was simple to use. So apart from just having it on the ambulance vehicle phones, they actually, a lot have it on their personal devices. So their own personal phones they carry with them every day and night. They have the app on the phone. And what happened was, outside of the boundaries of that Central Grampians region, I had crews that would less frequently come into Ballarat, but they wanted it as well. And at the time, we could only put it on their personal phones. And there's a couple of dozen at those scattered around smaller branches that have it on their personal phones and use it from time to time when they do come to Ballarat. So it can work across a broad area and even outside our target area that we had initially planned for. So it's got scope to go a lot further and into metropolitan areas as well. If we've seen the results we've seen in a couple of hospitals, Ballarat and Bendigo, it would be transferable that we would see it in the larger metropolitan hospitals as well.
Great. Once again, we have a number of questions, and if we did not get to your questions today, do not worry. We will actually reach out to you directly, answer any questions that you might have, follow up with you. We're going to have one final question, and this is for you, Chris. It's a common question. It says, how much does Pulsera cost, and what is my next step if I'm interested in pursuing Pulsera?
Oh, gosh. Okay. Pulsara is, the costing is quite variable, and it does depend very much on the size of the hospital and the volume of cases coming through the ED. it can cost, and you know, that's a cost that can vary a lot. Obviously, for some of the moderate-sized hospitals that we've had in Victoria, in the regional hospitals in Victoria where we've implemented this, you're looking at around, I guess, $30,000 or $40,000. But look, you know, there's all things that there is a lot of variation, and of course the exchange rate is also an issue, which at the moment I have to say is quite favourable for the Australian dollar. So that is good news. I guess the other element to that, though, is it's important to look at the context, right? So there's a couple of elements. Firstly, I find that when we talk about these sorts of digital tools, usually the more simplistic and easy to use they are on the surface belies the complexity and depth of R&D that goes in under the hood to actually produce that simplicity. And I guess a good example is probably my iPhone, right? You know, a 4-year-old can pick this up and work it, but you know, that's decades of work that's gone into that, and to make it work and appear as seamless as it is. That's the first thing. So it's very simple to use. The other element is the context, and what we have found is that because of the value in this sort of communication and improvement in patient care, you have to look at what would be the alternative. And the alternative is that the old days where you would have a low threshold for transporting patients out of regional hospitals into a metro environment, right? So for many hospitals, particularly in regional Australia and certainly regional Victoria, the cost of a transfer is very expensive. And so what you may not be aware is, for example, a helicopter transfer costs about $25,000 Australian per hour. When you put the key in the ignition of the helicopter and you turn it, you've already clocked over $5,000. So if you prevent just one transfer from your hospital, be it by air or by car or whatever, then you have automatically covered the cost of using Pulsara. So in a whole of system approach to this, and in Australia, usually the hospital that's sending the patient covers the cost of that transfer. So if you're able to prevent that sort of movement of patient, you are saving considerably on cost, added to which the other sort of maybe less tangible elements to this, you know, moving patients out, of course, is very disruptive to the patient. It's not good for medical care. It was not ideal for medical care. It's not ideal, certainly not ideal for family and loved ones when the patient suddenly disappears from their region. So we find that the cost of Pulsara is not an issue for us, that all the other elements in the costings more than cover, you know, what the initial outlay would be. And the other thing, I guess, important, like any bit of technology that you buy, what you want is you want to pay up front for the technology that you purchased, but the bang for the buck, the serious bang for the buck, comes in the background support. So, you know, I can buy really cool technology, but if I've got zero background support, then I'm really thinking, do I want to buy this? Because if something happens and I haven't got anyone I can turn to, I'm on my own here. And I have to say that, again, without wanting to appear as a Pulsara salesman, and as Chris highlighted, I'm getting no money for this, but you know, we've had a fantastic working relationship with Pulsara, and their support has been excellent. So, you know, I think the cost is not an issue, and I'm going to really sort of go out on a limb here and put myself in hot water. But I have to say, for what we get, I think it's cheap at the price. So please block, all Pulsara people can block their ears for that one.
Chris,
but, yeah, it's fantastic.
Yeah, I think you spoke to it when you're putting in context about holistically the cost. Man, there's a lot more to it. And if anybody has any questions, I think the follow-up is that if you're interested, particularly in the Australia area, Michael Drummond is our contact in that local region. or you contact us at Pulsera. We would love for you to get a hold of us. Bottom line, there's a ton of great information here. It's the top of the hour. We value everybody's time. So for our audience, we want to share that this team has provided additional resources for you. They include contact information, downloadable case studies, on and on. We hope you can take these best practice and words of wisdoms and apply them in your community. The four of you guys are amazing. Thank you so much. By paying it forward, the great work you've all done will be an inspiration for others in Australia and beyond across the globe. Thank you.
Thank you, everyone.